name is Hayden Scott. I am an EMT intermediate. I'm also the program director for EMS University San Antonio. Today we're going over cardiac emergencies, including angina, acute myocardial infarction, congestive heart failure, and AED or automated external defibrillator use and operation. Here we see a diagram of the heart. Note the blood flow through the heart, how it enters the right atrium through the superior and inferior vena cava. Once the right atrium contracts, it pushes blood through the tricuspid valve into the right ventricle. The right ventricle will then contract, forcing the blood through the pulmonary valve and into the pulmonary artery. It should be noted that the pulmonary artery is the only blood vessel in the heart or in the body that carries deoxygenated. The blood will then circulate through the lungs, where it will gain oxygen, and then be pumped back into the heart from the pulmonary vein. Again, this should be noted that the pulmonary vein is the only vein in the body that carries oxygenated blood. The blood enters the left atrium via the pulmonary veins. The left atrium will then contract, pushing the blood through the mitral or bicuspid valve into the left ventricle. The left ventricle will then contract, pushing blood through the aortic valve and into the aorta for circulation throughout the body. There are three familiar cardiac conditions that you will see in EMS. These are angina pectoris, an acute myocardial infarction, and congestive heart failure. First, we're going to look at angina pectoris. This is chest pain. However, there is no permanent damage to the cardiac tissue. The signs and symptoms of angina pectoris are dyspnea or shortness of breath, nausea, profuse sweating, generalized weakness, and a squeezing feeling in the chest or tightening. An acute myocardial infarction is when oxygen can't reach the cardiac tissue, muscle tissue in the heart. This is usually caused by either a clot in the coronary arteries or plaque buildup. This leads to injury and death of the cardiac muscle tissue. The signs and symptoms of the AMI are radiating pain. This is sometimes, not always, dyspnea, which is shortness of breath, indigestion, and generalized weakness or fatigue. Your patient may present with all or none of these symptoms. Congestive heart failure is when the left ventricle, which is weakened by a heart attack, causes fluid to back up into the lungs. This, of course, is a simplified explanation for CHF. There is a failure to pump blood effectively to the rest of the body. This results in a systemic edema or pulmonary edema and rales. Difficulty breathing while supine that is not associated with a fever may be indicative of congestive heart failure. Treatment for the patients in respiratory distress with associated crackles and other symptoms of CHF require that you place the patient in an upright position unless the patient is not comfortable. However, it should be noted that you should get the patient as elevated as possible. Congestive heart failure is left-sided heart failure. This presents with hypertension and rales. Rales are identified as the clicking, rattling, or cracking noises heard upon auscultation of the lung. This is caused by the popping open of small airways and alveoli that are collapsed by fluid exudate or a lack of aeration during expiration. Your patient might potentially have JVD or jugular vein distension as well. They will also have peripheral and central edema. More often than not, they'll have the peripheral edema in their hands and feet. Now, cor pulmonale is right-sided heart failure. These patients will be either normo or hypotensive. They will have clear lungs, and their jugular veins will be flat or non-distinct. Your patient may also present with traumatic chest pain. This most often affects the chest wall, but it can affect the heart as well. Chest pain associated with blunt force trauma may result in the failure of the chest cavity to fully expand. This can in turn lead to hypoxia and can result in the death of the patient if they do not receive rapid care and transport. For pulseless adult patients, you need to perform immediate CPR with AED if possible. For your child and infant patients, a pulse rate of less than 60 in an infant indicates CPR. Check with your equipment manufacturer and your local protocol for AED for infants and children. The newer AEDs nowadays have pediatric attenuators for the child and infant. The new American Heart Association CPR guidelines indicate the use of an AED in the child and an infant as well. For your responsive patient, perform your initial assessment. Do not forget your OPQRST history, onset, provocation, quality of pain, radiation or region, severity, and time. Perform a focused history and physical exam. Place the patient in position of comfort. For your cardiac patients that complain of pain or discomfort, 100% oxygen, and assess vitals frequently, about every 5 minutes. For the automated external defibrillation, or AED, remember the chain of survival: early access, early CPR, early defibrillation, and early ACLS. The implementation of early defibrillation programs increase the survival outcomes, usually by about 75% within the first 4 to 6 minutes of a witnessed arrest. There are two types of AEDs. One is a fully automated AED. This operates without any action once it is placed on the patient. All you have to do is hit the power button. The second type of AED is the SemiAutomated AED. This requires the EMT to utilize action buttons. Cardiac rhythms. The AED evaluates and confirms a shockable rhythm. They are highly accurate. However, they are not 100% accurate. These also depend on properly charged batteries. As in any machine, errors happen. AEDs can deliver inappropriate shocks. This can be due to human error as well as mechanical error. The mechanical errors usually occur when there is an outside artifact that the machine reads. AEDs will shock only two rhythms. The first one is ventricular fibrillation. As you can see, there's no rhyme or reason or regularity to this rhythm. The second one is ventricular tachycardia. Ventricular tachycardia will be shocked by an AED as long as there is no pulse on the patient. AEDs do not determine if the patient is in cardiac arrest or not. They only determine whether to shock based on the heart rhythm. AEDs are also proven to be quicker at delivering the first shock than any manual defibrillators. You must stop CPR, bag valve mask, or any patient contact during analysis or when shocking. Prior to shocking a patient using the AED, you must ensure that no one is touching the patient or anything that might conduct the shock. This includes metal or water. They are both excellent conductors of electricity. In order to use the AED on a cardiac patient, you must take the BSI techniques properly. This includes gloves, face masks, etc. You stop CPR. Verify the patient does not have a pulse. You will resume CPR. If you notice any nitro patches, remove them carefully. Remember to remove any transdermal medication patch with a glove on. If the patient has a transdermal medication patch on their chest, remove it and wipe the area prior to delivery of a shock. The reason for this is the medication is usually water-based. Water conducts electricity and could cause issues as far as delivering a shock. If your patient has a pacemaker, do not put the AED pads directly over the device. You must place them at least 1 inch away, usually to the right or just below the pacemaker, depending on how far up and to the left the pacemaker is. Moving hair away can be accomplished by either removing the electrodes quickly, creating the quote-unquote waxing effect, or using a sterile razor. Most AEDs nowadays have a first responder pack attached to them. These carry CPR masks, gloves, as well as double-sided sterile razors. You will then attach the device to the patient. Some have color-coded wires. White goes to the right upper chest. Red goes to the ribs, usually mid-axillary, right above the last rib. However, most devices have AED pads that have pictures depicting the exact placement of where the pad should go. You will then turn on the power to the AED. You will stop CPR and clear the patient. This will initiate rhythm analysis in the AED. If the AED advises shock, you will deliver the shock and resume CPR as advised by the AED. Newer AEDs follow the American Heart Association 2010 guidelines. However, older models may not. Again, this cannot be stressed enough. Do not defibrillate on top of a pacemaker. Keep an inch or two of clearance. If your patient has a pulse, check ABCs. Is the airway clear? If so, are they breathing adequately? What is the rate? Provide 100% oxygen and transport. However, if they are not breathing adequately, ventilate with 100% oxygen via bag valve mask and transport immediately. If your patient has no pulse, resume CPR for 2 minutes. Start with compressions and then breaths at a ratio of 30:2. Transport as soon as possible. You must note, do not touch the patient during rhythm analysis or shock delivery. Follow the manufacturer's recommendations on when and how often to shock and or perform CPR. This also can be outlined in your local protocols. During transport, on an unconscious patient, reassess the ABCs every 30 seconds. If your patient becomes pulseless, stop the ambulance immediately. Your AED cannot analyze while in motion. It is also not safe to defibrillate while the ambulance is moving. Continually monitor your patient and do the following. Continue chest compressions if required. Ventilate with oxygen and advanced airways and suctioning as per protocol. However, always leave the AED in place. It will not affect CPR or any other treatments. Repeat your ABCs frequently and contact ALS immediately. This way they can consider pronouncement according to the local protocol. You must regularly maintain your AED. There should be a daily operator's checklist that checks the batteries, cables, patches, and confirms proper operation of the AED. AED failure is usually related to improper maintenance and can usually be attributed to battery failure or improper charging. Now we're going to go over the key differences and changes in the American Heart Association guidelines. Uh, the major guideline that has been changed is the CAB sequence. However, you cannot confuse this with the ABCs of the patient assessment. For the last 50 years, the American Heart Association has taught ABC, airway, breathing, and chest compressions. Now, ABC has changed to CAB, chest compressions, then open the airway and give 2 rescue breaths. In 2005, the sequence of adult CPR began with the opening of the airway, checking for normal breathing, and then delivery of 2 rescue breaths, followed by cycles of 30 chest compressions and 2 breaths. The 2010 guidelines state to initiate chest compressions before any ventilations. By changing this sequence, chest compressions will be initiated sooner, and the delay in ventilation should be minimal, no more than about 18 seconds. Look, listen, and feel in 2005 was used to assess breathing after the airway was opened. However, according to 2010 guidelines, look, listen, and feel was removed from the CPR sequence. After delivery of 30 compressions, the lone rescuer then opens the victim's airway and delivers 2 breaths. This is because breathing is briefly checked as part of the check for cardiac arrest. This way, after the first set of compressions, the airway can then be opened and the rescuer immediately delivers 2 breaths. Chest compression rate has not changed because it is a reasonable idea for the lay rescuer and healthcare provider to perform chest compressions at a rate of at least 100 per minute. The number of chest compressions delivered per minute during CPR is an important determinant of return of spontaneous circulation and survival with good neurologic function. An inadequate compression rate or frequent interruptions, or both, can and will reduce the total number of compressions delivered per minute. The depth of chest compressions. In 2005, the guidelines stated that the adult sternum should be depressed approximately 1.5 to 2 inches, or 4 to 5 centimeters. However, in 2010, the adult sternum should be depressed at least 2 inches, which is a minimum of 5 centimeters. Rescuers often do not compress the chest enough, despite recommendations to push hard. In addition, the available science suggests that compressions of at least 2 inches are more effective than compressions of 1 inch. Now we're going to review the changes in child CPR. In 2005, the guidelines stated that CPR was initiated with opening of the airway and provision of 2 breaths before chest compressions. However, in 2010, the new guidelines state that initiating CPR for infants and children with chest compressions rather than rescue breaths, again CAB rather than ABC, CPR should begin with 30 compressions for a lone rescuer or 15 compressions if you have 2 providers, rather than the 2 ventilations. For resuscitation of the newly born, we will have a neonatal resuscitation section further in the lesson. Most pediatric cardiac arrest victims do not receive any bystander CPR. So, remember, any strategy that improves the likelihood of bystander action may save the lives of children. Again, in 2005, the guidelines stated that look, listen, and feel was used to assess breathing after the airway was open. However, this was removed in 2010 from the sequence for assessment of breathing after opening the airway. Because of the new chest compression first sequence, CPR is performed if the infant or child is unresponsive and not breathing, or only gasping, and begins with compressions, thus eliminating the need for look, listen, and feel. Defibrillation of infants. The data in 2005 had shown that AEDs can be used safely and effectively for children aged 1 to 8. However, at the time, there was insufficient data to make a recommendation for or against using an AED in an infant less than a year of age. However, in 2010, for infants, a manual defibrillator is preferred to an AED for defibrillation. However, if a manual defibrillator is not available, an AED equipped with a pediatric dose attenuator is preferred. If neither is available, an AED without a pediatric dose attenuator may be used. The newer case report suggests that an AED may be safe and effective in infants. Because survival requires defibrillation when a shockable rhythm is present during cardiac arrest, delivery of a high-dose shock is preferable to no shock at all. There is limited evidence that supports the safety of AED use in infants. Congratulations, this completes part 1 of the EMT